and welcome to EMS Research with Professor Bram, where we talk about EMS-related research that connects well with first responders, physicians, and paramedics that are in the area of first response. Today, we're going to talk to an expert on venom research, so hold on for the interview. My name is Bram Duffy. I'm a research fellow with the Institute of Social Innovation at Fielding Graduate University. Like many of you, I've been in healthcare for over 20 years. I'm a paramedic and have done critical care and 911 as a history. And I've taught over 60 college-level classes in areas like communication, leadership, and EMS. My own research has a lot to do with how paramedics communicate. I actually have a research study open now for paramedics, so if you don't mind being interviewed by me, then go to my website at professorbram.com, that's professorbram.com, click on current research to apply. In essence, my focus is on discovery and learning, aiming to equip you with invaluable knowledge, since EMS research data can also be elusive. Frequently, it finds itself obscured behind paid walls or other methods that are just difficult to access unless you already belong to an institution that gives you that access. So whether you're a EMT, firefighter, nurse, or physician, this is a podcast with you in mind. So before we get started, I want to share with you that I've written 2 books on communication. The most recent was a book called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. You can find a link to the book below, and then for sure hang out to the end and I'll tell you more about it. So today we talked with Dr. Spencer Greene, who's a medical toxicologist and director of toxicology at HCA Houston Healthcare in Kingwood, Texas. He's also a clinical professor at the University of Houston College of Medicine, and he's published a lot of research studies about snake bites. And so he's here to tell us a little bit about a few of them. So Dr. Greene, welcome to the show. Can you just tell us more about you than I did in the introduction about yourself?
Sure, and thanks for having me. So I'm a medical toxicologist, as well as an emergency physician and an addiction medicine physician. And at my job at Kingwood, I am responsible for seeing all the toxicology patients. And that includes things like intentional and unintentional overdoses, and any occupational exposures, any adverse drug reactions, and of course, envenomations. We're lucky, or not, depending on how you perceive it. We have one of the busiest snakebite services in the United States. So I see dozens, possibly 100 snake bites this year. But we also see spider bites and occasionally scorpion stings, marine envenomations, and on occasion some obscure things like Gila monster bites, even though Gila monsters are not native to Texas.
You know, like, people may not know how special it is to find someone like yourself because, you know, out of all of the emergency room physicians that I know, and of which there are many, very few of them give a care about research stuff. You know, they're very interested in their practice only. And so you have all these layers to yourself because you're an expert in medical toxicology and the ER piece. And today we're here to talk to you about the research that you've done on snake bites in particular. And so I have gone through and pulled some of the research studies that you've done, and hopefully we can get to the bottom of some of the more interesting ones. A lot of this is about snakes today. So our first study that you wrote was called Epidemiology of Fatal Snake Bites in the United States. And this was a study that looked into the details of those rare cases where snake bites result in death. The researchers went through the records from the American Association of Poison Control Centers from '89 to 2018 and found 101 cases where people died from a bite that was native U.S. snake. So out of those, 90% were caused by rattlesnakes. There were also a handful of deaths caused by copperheads, cottonmouths, and one by an eastern coral snake. Most of the people who died were men, and the average age was around 40 years old. Interestingly, many of these deadly encounters with snakes weren't accidents. They happened to be when people were intentionally interacting with the snake. So what's the takeaway here? Well, if you're bitten by a snake in the U.S., chances are you'll be all right, especially if you get medical help quickly. Rattlesnake bites are the most likely to be deadly, but even then, deaths can be rare. Your risk group goes up if you purposefully mess with venomous snakes or if you're under the influence of alcohol or drugs at the time of the bite. And kids under 12 aren't particularly at risk, but older folks might have a slightly higher chance of not making it. So, Dr. Greene, tell us what else we need to know about this study. And just really, do you like snakes, or is this just a hazard of the job?
So, I love snakes. It's interesting. My background is in EMS, and when I started residency, well, first let's take a step back. When I started medical school, I knew I'd do emergency medicine. When I started residency, I figured I would complete my residency, fulfill my military obligation, and then become an EMS medical director. They didn't really have EMS fellowships back then. But shortly after I started residency, I met our toxicologist, and I was just amazed by this whole body of knowledge that she had. And I loved everything about tox. It's just stuff that most doctors never learn, and realize there's only a few hundred toxicologists in the country. So when you said it was kind of rare to encounter someone like me, that's actually true. There's only about 600 of us. Most are emergency physicians. But I loved everything about tox, but I didn't have any specific interest within tox. I loved the plants, the mushrooms, the snakes, the overdoses, the drugs, everything. When I was overseas and I was with the special ops unit, not doing a whole lot of stuff medically, I became kind of fascinated with the local fauna, and I became really interested in snakes, and that's what precipitated the whole thing. I ended up doing my fellowship in Phoenix because historically Phoenix treats the most snake bites in the country, and the rest is history. So yeah, I love snakes. I don't have any snakes in my house anymore. It's just overrun with cats now. But I do consult with the Houston Zoo, so I have access to snakes a lot. But I'll tell you that snakebite fatality paper is one of my favorite studies of all time because it was born from a legitimate desire to know the answer. I was curious one day. People are always asking, what's the most dangerous snake? What's the most deadly snake? And there's different ways of interpreting that question. You can answer it as the snake that's most likely to kill you if you're bitten, or you can answer it as the snake that kills the most people. And there's different ways to phrase it, and the answers to those questions are very different. We discovered that timber rattlesnake killed the most people, but you're more likely to die if you get bitten from, say, a western diamondback rattlesnake or a Mojave rattlesnake than you are if you get bitten by a timber rattlesnake. But there were certain features that were associated with the bites from timber rattlesnakes, including not seeking medical attention. One of the neat things about the study was that all the deaths in Kentucky and all the deaths, I can't remember if it was Georgia or Alabama, were snake handlers who were intentionally handling timber rattlesnakes as part of a religious service, who either didn't seek medical attention or finally, toward the end of everything, decided to seek medical attention, but certainly did not seek medical attention quickly. And as you mentioned, if you get medical attention, death is rare. There's an average of 3.4 snakebite fatalities annually in the United States, not 50, not 100. I recently asked somebody who was there with a patient who got bitten to guess how many deaths there were each year, and he guessed 100,000 deaths in the United States, which of course is not even close.
Right.
So the study was interesting. It told us, that most people are going to be fine. But what was interesting also was the epidemiology. A lot of people don't understand how most snake bites in general happen. There's this perception that's often pushed by herpetologists that most bites occur when you're messing with the snake, and that's completely untrue. The overwhelming majority of bites occur when someone is unaware of the snake. They're walking outside at night wearing flip-flops or their Crocs or barefoot, and they step on or near the snake. That's the overwhelming majority. We published a study years ago using data from the North American Snakebite Registry, and we found that only 19% of bites were the result of intentional interaction. 81% were just people were not aware of the snake, and they stepped on it, or they reached into a bush and got near the snake. And ours is not the only study to have that conclusion. The University of Arizona Poison Drug Information Center, using a completely different data set, found only 12.6% of bites were the result of intentional interaction. And a more updated study using North American Snakebite Registry found 14.5% were the result of intentional interaction. My own numbers for the last 2 years, it's about 15 to 20% intentional, the rest unintentional. And that's different from the fatalities paper. Most of those people were messing with the snake. Similarly, alcohol was involved in a significant amount of the fatalities. But in general, alcohol is not associated with snake bites. There was a huge study that they published out of Dallas looking at over 90,000 snake bites reported to poison centers over the year. And they found that the incidence of concomitant alcohol use in snake bite was less than 1%, especially low in kids, like how a lot of drunk kids getting bit. But less than 1%. Whereas alcohol was a significant factor in a lot of the fatalities. Now, I think the 1% is kind of low. In my own numbers, it's about 10%, but still, 1%, 10%, it's not the majority. Most people getting bitten are not drunk guys messing with the snakes. They're people walking their dog at night or going to pick up the trash or whatever, just wearing the wrong feet.
So because of
footwear.
that, would you say that it's not as much of a judgment issue, but it's a fact that the alcohol's in your body, so the venom is going to have a worse effect? Because when we talk about alcohol, I immediately think, oh, well, these people have bad judgment because they're drinking,
Right.
and so they mess with snakes. But maybe that's not it. Maybe the alcohol caused them to have an accelerated reaction to the snake.
I think the major issue with alcohol and fatalities is the judgment. No question about it. That's the major one. That said, people are more likely to incur injury after the bites. They fall down, for example. In fact, when I was a fellow, we often had patients who were admitted to the trauma service with a semi-related toxicological exposure. One example was someone who was stung by hundreds of honeybees, but then fell down a cliff in an effort to escape from the honeybees.
Yeah.
Somebody else was under the influence of psychedelic mushrooms, and they wouldn't have hurt him so much, but he fell off a cliff. And even the fall off the cliff wasn't the big danger. It was the sudden deceleration of the end of the cliff. That was the problem. So they end up on the trauma service. But yeah, I think, with fatalities, it's because people have poor judgment, which leads them getting bitten and then leads them doing dumb things up to including not seeking medical attention. You mentioned the coral snake bite. It's the only recorded death from a coral snake in the last 60-something years, and the gentleman did not seek medical attention. Had he gone to the hospital, he could have been saved.
Wow. Yeah.
And just because I mentioned coral snakes, and they are my favorite native snakes, I got to tell you, there's so much misinformation out there and so much confusion about coral snakes, starting with how we recognize them. There's this rhyme that we really discourage people from using.
Yes.
And especially in Texas, I really hate it because the first line of the rhyme is red on yellow, kill a fellow. Let me tell your audience right now, there are 0 human fatalities attributed to a Texas coral snake in the medical literature. There is no evidence that anyone has ever died from a Texas coral snake bite. Really painful, and especially in North and Central Texas, you can see some objective weakness, but what we don't see is skeletal or respiratory muscle paralysis, and people don't die. So I really, really want to dispel that myth. People don't die from Texas coral snake. Pets can, no question about it, but humans do not die from Texas coral snake bites, nor do they die from the Arizona coral snake, and rarely do they die from the eastern coral snake in Florida.
So I want to go back to something that you'd mentioned earlier about how the fact that a lot of people may get bit and they don't know what they got bit by, right? You're in the sandals, you're at night, and you got bit. I'll tell you, even as a medical provider myself, I don't see snake bites that much. The last time I saw a snake bite was at a Boy Scout camp years ago, so it's just rare for me. And so if I were to get bit by what I would think is a snake in the dark and doesn't know what happened, honestly, I would be in a state of panic and not know what to do right away either. So give us the best. What are we supposed to do? Like wrap a belt around it and cry? I mean, tell me the plan.
Well, you're welcome to cry, but don't, hopefully, because you'll be okay. But no, don't wrap a belt. In fact, most of the treatments that were previously recommended have proven to be useless at best, dangerous at worst. What do we not do? We don't suck and cut. You can't actually remove the venom. That's not going to happen. We don't tie anything. We certainly don't do a tourniquet. Tourniquets are great for life-threatening bleeding, but you don't want to cut off the blood supply to an injured limb. Now you're just going to make it worse and increasing the likelihood of permanent damage or even tissue loss or limb loss. So you don't do anything tight, not a tourniquet, not even a constriction band. We don't do that here in America. And I say that because it is reasonable to do that if done correctly in places where the bites are exclusively neurotoxic. But considering that most of our bites in the United States cause tissue injury, in fact, most of our bites cause nothing but tissue injury, you don't want to do anything that's going to be tight. In fact, we remove anything constrictive, any jewelry or clothing that's tight, we remove it. We don't cut and suck. We don't pack it in ice. We don't use one of those extraction devices, that are sold in sporting goods stores and chemistry. They don't actually remove venom. All they do is cause a negative pressure injury. They can actually concentrate the venom. And that's why my favorite editorial title of all time, it was published in February 2004, in the Annals of Emergency Medicine. It's written by my friend and colleague, Sean Bush, and it says, venom extraction devices don't remove venom, they just suck.
Yeah.
Because they do, they're horrible. And he and I were 2 of the 11 experts that were interviewed for a report trying to get these off the market because they are not helpful whatsoever. They're only good for making profits for the manufacturers and the distributors. What should you do? Don't panic because you'll probably be fine. Have someone drive you to an appropriate facility. And I emphasize appropriate because you pointed out that most people are unfamiliar with bites. And what I see in my neighborhood, in my community, doctors at other hospitals, they don't see a lot of bites. and they don't manage them right. They just don't know how to manage them because they don't see them enough. And what they've learned from people who also don't see a lot. We're lucky at our hospital. We see, dozens of bites a year. I may see 100 bites this year. Last year I saw 80, which is, one of the busiest services in the country. We not only read the literature, we contribute to the literature, we write the literature, and we're at the cutting edge. And most places don't do that. And I hear a lot of places they do things like they don't give antivenom when it's indicated, or they fail to elevate. And that's one thing that you can actually really do to help people in the pre-hospital environment. Historically, it was taught to keep below heart level. If you go to the CDC website, it says keep the affected limb below heart level. What we know now, that is actually harmful because it exacerbates the local damage. Knowing that what we see is primarily tissue injury, we actually recommend early and aggressive elevation. And people do better. In fact, sometimes elevation suffices. Many times they need antivenom, but sometimes elevation is enough. So if you get bit, don't panic, don't freak out. Don't grab the snake because I don't need to know the snake. And that's an important thing too. You said, you might not recognize the snake. Another mistake I see, other doctors do, they won't treat the patient because they can't tell the snake. We never have to know the snake ID to successfully treat someone because it's one of two things if they're bitten by a native snake. Well, one of three things. It's either a non-venom snake, which is going to cause no symptoms, it's a coral snake, or it is a pit viper. And by pit viper, I mean copperhead cottonmouth rattlesnake. Although they're all different and they tend to vary somewhat in the severity, rattlesnake bites, copperhead bites, cottonmouths, they all look the same and they get treated the same way with the same antivenom. So I actually don't have to know the species. Coral snakes look nothing, the bites look nothing like bites from pit vipers. Pit viper bites have swelling, they have bruising, they have a shininess to the skin, and they feel like they're hit with a sledgehammer. They may have bleeding abnormalities. Coral snakes, it's like you're hit with a taser. There's minimal swelling, there's no bruising, there's actually more redness with coral snake bites than there are with the pit viper bites, but they feel like they're being tased. It's a completely different clinical picture. And that's why we don't have to know what species, and that's why you don't have to bring the snake. So I really discourage bringing snakes because if you bring a live snake, obviously that's a danger to everybody. If you bring a dead snake, well, that sucks because I love snakes, but also it's still a danger. People have been bitten by dead, decapitated snakes. There was a guy in Corpus 3 years ago who almost died after getting bitten by a decapitated western diamondback rattlesnake, and that made all the news. A few years before that, a guy died from a decapitated prairie rattlesnake in South Dakota, and that made no news, probably because there are fewer people in South Dakota. And then there was a case in Virginia where someone was envenomated by a decapitated copperhead and had a significant envenomation. So don't bring the snake, dead or alive. Don't freak out. Just go to the right place. Don't do anything stupid. Elevate and get treated by someone who knows what he or she is doing. It's really simple.
So from a paramedic perspective, I'm going to elevate the wound and treat for pain management.
Exactly.
What about a PO challenge? I mean, not PO, a fluid challenge for IV? Would that be good or bad?
It's funny you ask because we had this big discussion yesterday. What we consider sort of the Bible for the management of snake bites is the Unified Treatment Algorithm, which came out in 2011. I was not involved with it originally because I was still early in my training, or early in my career. I'm now one of the authors for the updated version. And we debated at length about IV fluids. In rattlesnake country, it's not uncommon for people to be really volume depleted. They'll come in, they'll be hemoconcentrated, they'll have lost a lot of fluid, and it's essential to fluid resuscitate those people. But in copperhead country, we don't really see that. And what I often see EMS people do is they want to be aggressive. They give a ton of fluid. Well, they don't need it to maintain, perfusion. And if you have this affected limb with increased capillary permeability and you're giving all this fluid, where do you think that fluid goes? My concern is that you can exacerbate the local swelling. So I think it's important to get IV access and maintain euvolemia, but don't go crazy. Don't dump 3 liters into these people. And especially if they have comorbid conditions. Imagine if they have CHF and now you're giving them a gallon of, crystalloid. That can exacerbate, systemic toxicity. So I think it's important to maintain euvolemia, but don't go nuts with the fluid.
The reason I say that is because, some people have weird ideas about this, like, I can dilute the poison or something.
You cannot dilute the venom, Yeah, it's one of the many, many things we hear. So no, the best thing you can do as a pre-hospital provider is, get them into safety or to get them away from danger, elevate the affected limb, IV pain control. We actually discourage anything by mouth just in case they're going to have a severe reaction, or if they're going to have a reaction to the antivenom that they may get in the hospital.
In case they have to be intubated later.
Yeah. So and if they're nauseated from the opioids, we don't want them to vomit. I'd rather have their stomach contents empty. So pain control, good supportive care, and get them to the right facility because not all hospitals are created equal when it comes to snake bites.
Yeah, we know that. Well, your next study I want to talk about comes to us from the Annuals of Emergency Medicine with an article called "The Efficacy of Crofab," which is ovine antivenom, versus placebo plus optimal rescue therapy on recovery from copperhead snake envenomation. So that's a long title to say
Yes.
that you looked at copperhead bites. And we already know that being bit by a copperhead snake isn't usually life-threatening, but can cause long-lasting injury to that limb. In this study, Dr. Greene and other researchers wanted to find out if if giving the patients the antivenom treatment would help improve the function of that affected limb. And so they looked at patients who had a mild envenomation from copperhead snakes, studied 74 patients total, and out of these, 45 were given the antivenom treatment. So they found that those who received the antivenom had a better limb function after 14 days compared to those who didn't get the same treatment. So whether the patients received the treatment or not, all of them recovered fully within 4 months. And interestingly, those who got the antivenom used fewer opioid painkillers. So in terms of what this means for doctors and patients, the results suggest that the outcomes are generally good for people with a mild to moderate envenomation from copperheads. So using antivenom might help improve limb function sooner and not have to be stuck with painkillers. So Dr. Greene, tell us about these copperheads.
So this is arguably the most important study with which I've been involved. I wasn't the principal investigator. I wasn't the primary author. I was one of multiple local PIs. I saw patients at 2 of my hospitals back then. But for years, people have minimized the significance of copperhead bites. They say, oh, well, it's copperhead, no big deal. Even now, people are like, oh, you have a copperhead, we don't have to do anything about it. Death, you're right, is not common, although there have been 6 fatalities attributed to copperheads in the last 33 years.
Aren't these the snakes that chase you?
No.
Okay.
No snakes chase you. But that's the cottonmouth, which is also not true.
Okay.
That's the myth. But no, copperheads don't chase you. Actually, non-venomous water snakes, they're little jerks. They'll chase you. But they're not venomous in the classic sense. But no, the myth is that cottonmouths, a.k.a. water moccasins, they chase you, not copperheads. Same genus, different species. But copperheads, people have minimized the significance of copperhead bites. And historically, they went untreated. We wanted to know, do people benefit from antivenom? And we did the only randomized clinical trial ever done looking specifically at copperhead bites. And we excluded severe bites because it would be unethical not to treat those people. We looked at mild and moderate bites, primarily mild bites. And what we found was that there was a clinically and statistically significant difference between people who got treated and those who didn't at 2 weeks. And that confirmed what I know from my very busy practice. There's no question that people who get treated do better faster. They get back to work faster. They get back to doing their hobbies faster. And what was really cool about this study is we looked at patient-centric data. We didn't look at obscure outcomes like death, which fortunately is so rare, or lab values that may have no clinical significance. We looked at what matters to the patient, how much he or she could do the things that mattered, the things that they identified as important to them, whether it's cooking or playing tennis or playing golf or wrestling with their dolphin, whatever. Mm-hmm. We didn't have a lot of patients who like to wrestle with dolphins, but they could have chosen that as one of their activities. We found that there was a big difference at 2 weeks. And although in our study everybody recovered, we know from other studies that up to 20% of people with copperhead bites don't fully recover. They have long-term or permanent disability, long-term being defined as more than a year. And in our study, everybody did recover, but there's no question our guys, the ones who got treated, got better faster. Mm-hmm. And again, they required fewer opioids, and that's important in this day and age of opioid addiction. Like I said, I'm an addiction medicine physician, and we know that long-term opioid use is an increased, is a risk for dependence and misuse. And at every time point, the people who got treated required fewer opioids for a shorter duration. Mm-hmm. So yeah, what we concluded is that even mild bites, antivenom should be considered, should be offered, and this is an ongoing battle. At so many places, they minimize copperhead bites. And they're like, well, it's not worth the expense, or it's not worth the danger. And yeah, antivenom is expensive, but A, if you have insurance, it's covered the same way that other medications are. And B, it's also expensive to have a long-term disability.
Yes.
And as for safety, the antivenoms we use these days are very safe. They're very different from what we used before the year 2000. The antivenom before 2000 was effective, but had an acute adverse reaction incidence of like 25 to 56%. And anyone who got more than 10 vials had a 100% incidence of serum sickness a week or 2 later. What we see now, it's anywhere from 1.4 to 10%, and it's generally a mild acute reaction. And clinically significant serum sickness is negligible. So the antivenoms we use now are safe, they're effective, and while they're expensive, so is not working. You know, so is never being able to do your job again.
So when we talk about, now that I'm with the expert and we're talking about antivenom, I want to sort of push an idea that some of my viewers may have. Do you have to go to the zoo to get some antivenom stuff? Like, do you mix up your own concoction sometimes?
So
those are ideas that they push in the media, so I don't know.
Most hospitals in areas where snake bites are common have their own FDA-approved antivenom. And there are 2 antivenoms that are FDA approved for treatment of North American pit vipers. And again, pit vipers are copperheads, cottonmouth rattlesnakes. So we don't have to know the species. We just have to make the diagnosis of pit viper envenomation. The hospitals have them. What hospitals don't typically have are coral snake antivenom, because that's rarely necessary, especially in South and East Texas, where their bites are confined to pain, and you can just treat that with pain medicine. And what hospitals are not allowed to carry are non-FDA approved antivenoms that we would use for non-native snakes. And because this is Texas and people can own whatever the heck they want as long as they have the $20 permit, barring a few jurisdictions, we get a lot of bites from non-native snakes. And for that, either people have their own antivenom, they filled out the paperwork to get their own antivenom, which is the responsible thing to do, or they rely on the zoo to get antivenom. And fortunately, we have a lot of different types of antivenom at the Houston Zoo, and we will provide the antivenom to the patient, to the hospital, and then hopefully get reimbursed for it.
So the zoo has it on standby in case one of those people get bit, or you're going in there mixing it up in a lab?
So the zoo has their own supply of antivenom in case one of their staff members gets bit. That's the primary reason that zoos have antivenom. If they have a venomous snake, they have to have the antivenom in case, God forbid, someone gets tagged. Fortunately, it's been a long time since anyone at the Houston Zoo has been bitten by a snake. I think it's been 15 years. But no, I don't have to make it. In fact, there's this myth, again, because of television, that you can just whip up your own antivenom. I blame the TV show Scorpion, but I'm sure other shows have also, misinformed people. Antivenom is a years-long process. It takes years to make antivenom. So you can't just whip it up. It's not like a souffle, which also takes a few hours. It's freaking, it's a months, if not years-long process. So no, we have the antivenom for many things. I recently had to treat a bite from a non-native snake from Mexico, and fortunately I had an antivenom that covered it. But the person who got bit had several hundred other snakes at the facility, and had the bite been from, say, a boomslang, the person probably would have bled to death, because I don't have access to boomslang antivenom nearby. I'd have to get it probably from Florida, and it may take 10 hours, and they could exsanguinate in that time.
So what happens if it takes 10 hours? How does that emergency transport happen for the antivenom? I mean, is somebody on standby to, like, a heart? Is it like when they have a heart transplant and you have somebody that's racing with that heart? Is that what they're? That's
similar.
Unbelievable.
Similar. So the good folks at Venom 1 down in Miami-Dade Fire Rescue, they have this huge antivenom bank with more than 50 products. Like I said, I have about a dozen products, maybe 14 at the Houston Zoo, but they have way more. So when I need something really obscure, I'll call them. Now, if someone doesn't go with it nonstop like a heart, they hand it off to a courier. So it's not one of their people, it's just someone they hire. And they fly it out to you, and it could be 4 hours, it could be 10 hours, depending on how many flights there are and to where they're flying it. And then they bring it to you, and we can give it. But if it takes 10 hours, you can have serious effects in the interim. And with a boomslang, the thing you worry about is bleeding to death.
Yeah.
And you can't just give blood products. That won't do it. You can't give, you can't give platelets, you can't give fibrinogen, you can't give cryo. You need antivenom. In fact, there's a really good description of how one dies from a boomslang, written by a herpetologist who was bitten by a boomslang. And he at first did not think it would be very serious, so he just stayed at home and documented it himself, and then he stopped writing because he was no longer alive.
Oh, no.
So had this person been bitten by a boomslang, it could have been a really bad outcome. And then had the bite been from, say, a crate, which is a neurotoxic snake native to Taiwan, I don't have the antivenom for it, but for neurotoxic snakes, what we worry about is respiratory paralysis. Well, we can just put them on a ventilator. It may be on a ventilator for days to weeks, but at least we can take care of that. But fortunately, this was a bite from a Mexican pit viper for which I had the antivenom at the zoo, and the patient went home the next day.
When I work on the ambulance, I'm lucky because my best friend is my partner, and he and I get to talk about, the show, and he knew you were coming on. And one of the conversations that he and I had was about how all these things out there that have tried to kill humans, we have dominated them and killed them first, right? There's a lot of animals out there that have gone extinct because as humans, we just weren't going to put up with it. So why do you think that we haven't done that with these snakes that are so incredibly venomous? Like, I'm not saying it's a good thing to make something go extinct, but I'm thinking, it's human nature to kind of go that direction. And so with these really, really dangerous ones, are there places where that's an effort, like they're just trying to kill them all because the natives are scared of them too? I was just wondering about, like, what your take on that might be.
So there are definitely people in places where they're trying to eradicate the snakes, but we have not been successful, and that's a good thing because, first of all, you can make the argument that snakes, deserve to live like any other animal. The moral argument. You can also point out that they have an important role in the ecosystem. They are great for rodent control, and rodents carry fleas that carry, diseases. So eradicating snakes could actually impact our health. But beyond the fact that they have a right to live and the fact that they have an important role in the ecosystem, snakes are directly beneficial to humans as well, beyond what I just mentioned. For example, as a paramedic, you've undoubtedly heard of the class of drugs called ACE inhibitors. Well, guess what? ACE inhibitors were derived from snake venom. Captopril came from the jararaca, which is a South American pit viper. Other medications have been derived from snakes and other venomous critters. Byetta, exenatide, which is an anti-diabetic medication, comes from Gila monsters. I think it's funny that they discovered this in New York, because trust me, I'm from New York, and there's no Gila monsters running around in New York. So the fact that they did this research at the Bronx VA Medical Center is just mind-blowing. But yeah, all these venomous snakes have proven to be beneficial because there's products that you can use from their venom that directly benefit, sick humans. So, and the other thing is, we're not going to eradicate them because there's a lot of them, and
too many out there.
So, but we shouldn't eradicate them because they're important. They serve functions. They serve functions that we probably don't even realize yet. So, if we were to kill them all, we would probably suffer consequences we couldn't even anticipate.
Well, it's good to hear that because, a lot of times it's easy to be one-sided and one way of, looking at things, especially when we as humans try to protect ourselves. We don't care about anything else. It's just like, preserve all. Now, the next study is found in the Journal of Emergency Medicine called Captive Black Mamba Bite Leading to Respiratory Failure. And this study is about a 26-year-old guy who got bitten by his pet black mamba while he was trying to pack it up to send it to another snake collector. And he arrived at the ER after being bitten on his forearm. He was feeling pain in that left arm, had a weird tingling sensation in his mouth, and was having problems breathing. His vitals were all checked and recorded, but the doctors only just found 2 small but painful puncture wounds on his forearm and no other swelling or bruising. And then within the next half an hour, his breathing troubles got worse. He started feeling weak. And so the doctors went ahead and put him on a ventilator and gave him a medicine called atropine. We all know that helps with secretions. So after that, he was given 5 vials of the special antivenom and admitted to the ICU. And the good news here is that he was taken off the ventilator in 18 hours and then able to go home the next day. So since then, he's been completely symptom-free. And so now, if you're an emergency physician, you might be wondering why this is important to you. Well, black mamba bites are different from the snakes that we're used to seeing as providers. And the symptoms are primarily neurological, which means they affect the nervous system. So these things like tingling, difficulty speaking, swallowing, drooping eyelids can happen as symptoms. And so in severe cases, we see progressive paralysis and respiratory failure. So, Dr. Greene, tell us about the black mamba.
So, black mamba is, I think, one of the most fascinating snakes. It's been, mentioned in mainstream media. I mean, the bride in Kill Bill volumes 1 and 2, right? Wasn't she Black Mamba? And I mean, that was Kobe Bryant's nickname. Mambas are these fascinating creatures and responsible for a lot of deaths in Africa. But interestingly, not as worrisome in the United States. In fact, someone recently asked me, and I said I'd rather be bitten by a black mamba than a rattlesnake here in the United States. Because, as you pointed out, what we worry about with black mambas, stop breathing. Well, you know what? I can be put on the ventilator,
Easy.
And then I can be taken off the ventilator.
Mm-hmm.
A few days later, I'm going to be back to normal. With a rattlesnake, I can have significant tissue injury. I can have significant bleeding abnormalities. I can have, end organ damage. As long as I can get definitive airway management, I'd rather get bitten by a black mamba. The reason people die in Africa is they can't get definitive airway management. Mm-hmm. Now, there's some other potential things we worry about with mambas. On rare occasion, we get cardiotoxicity. You can get the bronchorrhea, that's the fluids collecting. But again, airway control can manage that. But this was an interesting case. This is someone I knew well. I had treated him for some snake-related incidents in the past. And he's also called me about snake-related incidents affecting mutual friends of ours. And when I saw his name and number pop up on my phone, I said, all right, who got bit by what? He's like, I did. Black Mamba. I was like, oh, damn. And I wasn't in town when the bite happened. I was actually at a venom conference in San Antonio next to one of the curators of herpetology at the zoo, where we have the antivenom. So I told him to proceed to my hospital. I gave my staff a heads up. I had a resident working with me who was really good. And
But he wasn't driving himself, right?
No, his roommate drove him.
He needed an ambulance to drive him in case he stopped breathing, right?
Well, I actually told him to go, just get in the car and go, because it would be faster. Knowing where he lived, knowing where EMS was, I figured EMS would be an extra 20 minutes. And the best thing was for him to go to the hospital. And that's a judgment call, you know. You're right, EMS can provide definitive airway management, but I did the math and I figured he would get treated faster if he went directly by car. And because of where it happened and what time it was, I was right. So he got to the hospital within 30, 45 minutes. And everyone was expecting him. We knew exactly what to do. The funny thing is, because I was in San Antonio and the curator of herpetology was at San Antonio, we had to get a new pharmacist, new to our hospital, new to Houston, in fact, to drive down from the hospital to the zoo at night to get the antivenom to go back. But so I was coordinating everything over the phone initially. But yeah, he was a classic mamba bite. He had the respiratory stuff, the weakness, and then he got the bronchorrhea, and then he got the antivenom, and next day he was fine, and he's been totally good. Now the interesting is he was bitten on the forearm while packing it up to sell it. The person to whom he was selling it is someone I've treated
oh no
for a monocle cobra bite that we may discuss later on. And he's someone who's had bites before and since that particular incident.
That's crazy.
So,
that's
but
repeat customers.
Exactly. And I've treated probably like 40 people for 2 or more bites, including some I've treated for 5 or 6 bites. But what's important about the mamba bite is, yeah, locally he had minimal findings. And emergency physicians, whom I already mentioned before, may not see that many, bites in their career. They may minimize it because, the local damage is nothing. But we don't worry about local damage with mambas. We worry about the systemic effects. So they could blow off and say, there's nothing going on. His labs are fine. Well, yeah, but he's also not breathing very well. So we always do tests to assess their respiratory and skeletal muscle strength. We can do dynamometry. We can do negative inspiratory forces. We can put them on capnography because it's a lot more sensitive than looking at the pulse oximeter to determine if they're having breathing problems. And we knew he was going to have breathing problems. And fortunately, we got him intubated right away, and he did fine.
It's so good to hear you saving people because it's a lot. I want to talk about your cobra study. The study that you did on cobras was called Cobra Envenomations Requiring Mechanical Ventilation. So just what we're talking about. And I don't have the full time to read the description, but please tell us about cobras.
So cobras are a huge class of snakes. I must say class of drugs out of habit. And it's important to be species specific because when people just lump all cobras together, bad things happen. There was a case in Michigan years ago where someone got the wrong species of cobra and therefore they got the wrong antivenom. It was antivenom directed toward exclusively neurotoxic cobras, but it was a type 2 cobra which causes both neurotoxicity and tissue damage, and because that wasn't treated, the person lost a lot of tissue. So cobras, you can argue with the different taxonomists. There's about 20-ish species, 20, 25 species, whatever. And some of them are exclusively neurotoxic. Some cause neurotoxicity and tissue injury. Some can cause bleeding problems. And some of those, what we call type 2 cobras that can cause tissue injury, can also spit venom. And that can cause injury to your eyes. It's called venom ophthalmia and other effects from a distance. So it's important to know which cobra you're talking about because the antivenoms are different. The African cobras respond very well to several of the African products, but you wouldn't want to use those for an Asian cobra. They're different animals, literally and figuratively.
So when they spit, does it only cause a problem if it gets in your eye? Like if it gets in your skin, it's okay?
Generally, the eye is what we worry about. Skin, you can have a little local reaction, but generally not a worrisome one, whereas the effects in the eye can cause blindness.
Oh my gosh. You've taught me so much in this little period of time. I want to thank you again so much for being with us today.
Oh, my pleasure. Happy to be here.
I also want to invite you to check out my latest book. The book was already rated as Amazon's newest #1 release in emergency medicine category, which blew my mind. I co-authored the book with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis. So I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. This book works to change the way we approach and interact with the emergency patient that's in acute distress and will help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. You can follow the link below to find it or go to almost anywhere where books are sold to find it. You can contact me with proof of your order, like a screenshot or something, and I'd be happy to mail you an autographed sticker that would be designed to stick inside the jacket cover. I'm doing a research project related to paramedics who live in the United States, and I could use your help. So if you don't mind being interviewed over a video call, go ahead and head to my website and fill out the form at professorbram.com. That's professorbram.com. Thank you again for listening, and I look forward to sharing more insights with you in this next episode. If you enjoyed EMS research, please tell your friends and like, share, subscribe, just to help others get the message.